Welcome back, and thank you for joining us this session. This session is on cost and quality, which I think is a really topical issue in the health system, wherever you are. We've got 4 great speakers this afternoon, and we've only got an hour. So we're going to go straight into our speakers. We're going to take questions at the end, so we'll have 4 speakers each for 10 minutes, and then we'll have plenty of time for questions. So please do tweet your questions through, and we'll take this at the end. We also have some questions from the floor, so we'll have the microphone going right at the end. So I want to kick off. Our first speaker this afternoon is Sarah Gillham, and she's Domain Team Lead Medical Director for NHS England, and she's going to tell us about psychological care after stroke from national guidance to routine practice. Sarah.
Thank you very much. Although I'm currently working for NHS England to implement the outcomes of the NHS Outcomes Framework, when I did this work, I was working for the English NHS Improvement Stroke Programme, a very successful programme which has seen the implementation of the National Stroke Strategy so successful, in fact, that it's been reorganised out of existence by the current administration due to their aversion to body part-related improvements. So that's a shame, but that's how it is. So I'm just going to quickly run over what psychological care is and what we mean by it, just so that you're on the same page as me in terms of what I did in terms of improving it. So this is about thinking about the individual's personal needs, thinking about their mood, behaviour and cognitive problems, and identifying those issues at an early stage if they are going to become issues. And thinking about the individual's responsibilities and relationships and not just about their physical needs. I think there is very much a culture, especially in stroke care, of focusing on people's ability to walk, eat, talk, get around, and less on what actually makes those people tick, what drives them, and what makes them feel important and valued as a human being. It's about equity of access to treatment, and fundamentally, in a nutshell, it's about the promotion of mental health and well-being. So that's what we're talking about in terms of improving psychological care after stroke. Now, several audits and reviews of stroke services around 2010 to 2011 showed that things weren't actually going very well in terms of psychological care after stroke. The National Audit Office did a big survey of patients within their big review of stroke care and found that patients felt that psychological support was rated least satisfactory in terms of their long-term support after stroke. And the Care Quality Commission did a review of post-hospital stroke services very bravely. This had never been done before, and looked at the provision and availability of services across a particular area. So services that are there in green are those that are provided very well across a patch, and those in grey are not available. And you can see that the services at the bottom there, neuropsychology, psychological therapy and stroke counselling, were just not available in many areas. And the National Sentinel Audit of Stroke looks at the staffing on stroke units in terms of whole-time equivalents per 10 beds. And you can see all of these other professions here have a number of whole-time equivalents per 10 beds, but clinical psychologists don't even register as 0.1 per 10 beds. So whilst they're available, they're in very, very short supply. So that's what the review showed. What did the evidence and national guidance say about what should be done in terms of psychological care? And I looked at the national strategy, the National Mental Health Strategy, which came out in around 2011, No Health Without Mental Health, and also the National Institute for Health and Clinical Excellence guidance, which looks at all of the evidence for treatment and frames it into quality standards and guidance. And in a nutshell, the messages there were that mental health is everybody's business. And when I first started talking about improving psychological care after stroke with stroke teams, most of them said, well, we don't have a clinical psychologist, so what can you do? But the message very much from the evidence was it's everybody's job to take account of psychological care. It's about using individualised care, not having a routine formula for everybody, but looking at people as individuals and looking at their needs. About competent practitioners, using a stepped care approach, which I'll talk a little bit more about later, and then avoiding antidepressants for mild to moderate depression. And this, unfortunately, has been a first-line treatment in many stroke units to compensate for the lack of clinical psychology. So when somebody seems a bit depressed, the easiest route is to put them onto antidepressants, and that isn't an evidence-based approach. And then using collaborative approaches for moderate to severe depression, so joining up of mental health services with physical health services and having case management. I also went to the patients to find out what their experience of their psychological care had been, and also, more importantly, to find out what they thought it should look like and what they thought should be done. And I've got some great films from these ex-patients, these stroke survivors, to say what they really thought of psychological care after stroke, which are incredibly powerful, and I don't have time to show you today. But fundamentally, they were just saying, treat us respectfully, empathise with us, and be kind. And that's the very first step towards good psychological care. And Harry there on the extreme right said, you know, if somebody had just done that, if I'd just been able to talk to somebody, I don't think I'd have needed the psychiatry I ended up going to in the later stages. And that was very much a view of many patients that I spoke to. And actually, this took me away from my original approach in thinking that what we needed was more clinical psychologists, to thinking what we really needed is for the whole stroke service to really approach psychological care in a different way. So what was routine practice? At the time, we had a suite of measures called Accelerating Stroke Improvement, which came out of the National Audit Office report and focused on the areas of stroke care that weren't being particularly well practiced. And there was a measure of psychological support as one of these. So we were asking people to tell us what proportion of people with stroke had received psychological care for mood, behaviour or cognitive disturbance by 6 months after stroke. And we aspired to around 40% of people should have got that psychological care based on the numbers of people who are likely to have depression, cognitive problems and behavioural problems. So we asked the 27 stroke networks to give us some data about psychological care in 2010. And you can see they really struggled with that. This is 2 networks out of 27 that could give us data, and only 2 hospitals within those networks provided the data. And you can see in that first column, there's a hospital there where 50% of their patients were getting psychological care after stroke. And I got really excited about this, and then I looked at the numbers, and they'd given us data for 2 patients. So that was disappointing. And most stroke services told us that they didn't think that they had an adequate psychological care service for their patients after stroke. And even those that did felt that they couldn't measure it. They had no way of giving us that information or even having that information for themselves. So this was my start point. This was my project, improve psychological care nationally. There was poor availability of services, as evidenced by the Care Quality Commission review. Patients didn't know how to get the support, and those who did get support weren't very happy with it. There's an overriding culture of greater importance of physical health over mental health, little ability to measure services, and evidence for what should be done, but not really any practical guidance for how that evidence should be implemented. So my ambition was really to change that situation on a large scale, to define how practically to apply the evidence. And it's all very well having the evidence there, but if you're working on the ground clinically, it's one thing to have a book with loads of evidence in, and another thing to translate that into, so what do you actually do then? What do you have to change to make a difference, and how can you effectively do that? Ambitiously wanted to change the culture so that there was an equitable approach to mental and physical health, and then to implement this national measurement of psychological care, really just to get teams to know what proportion of their patients needed psychological care and what proportion were actually getting it, and was it effective. So I ran 6 national projects in 2010 around the country, and these were stroke teams from communities, from acute stroke organisations, from early supported discharge teams, who were all at a different place in terms of delivering psychological care, and wanted to make it better. So out of those projects, we got some key principles for improvement. So the first was, if you wanted to improve psychological care, you needed to use what you had initially. Don't go looking for something perfect, use what you've got. There are lots of people in stroke teams who know about psychological care. People have been measuring and screening for psychological care, but haven't organised it into a proper pathway. There's lots that people could do that they had already that they could build on. using a stepped care approach, which is making sure that people got care at the level of need, at the level that they needed it. So if you're upset about your stroke, if you're upset about your stroke diagnosis, that's a natural grieving process that you'd go through, in the same way that if you had a new cancer diagnosis or a diabetes diagnosis, you would need some adjustment period. You'd be anxious and upset about that. And that's the sort of thing that a trained stroke team can manage. At another level, at the next level up, where your anxiety is interfering with your rehabilitation, you might need a higher level of care provided by more qualified staff. And at the very highest level, very few patients who've got severe need would need more help from more qualified staff. I'm going to whiz through some of these slides because I'm getting 1-minute warnings, but in essence, we took all of this learning out to some national learning events, getting stroke teams together to teach them what the principles for application were, and really focusing them on what they had to do, what they were going to go away and do next week when they left the meeting, giving them the principles and giving them all of the information in a book that was very that was a practical application for how they could implement that work. So we empowered them to go away and do that, and then supported them after the events with the clinical stroke networks, following up their progress. We developed the Health Economic Case, which is a publication that I've put at the back, which demonstrated that good psychological care after stroke saves the services money, to give people a business case in order to be able to help them to implement that. The situation now is that around a third of services are reporting improved psychological care after stroke. Most of them are they're all achieving 40% of patients achieving good psychological care, and more of them are able to report it than ever before. There are more stroke units with access to clinical psychology, a 15% improvement since 2006, but it's going to be not until 2034 that they all have psychological services at this rate, so it needs to speed up a bit. And then the hard to measure outcomes are that clinical psychologists are being included in new stroke service specifications. Staff competencies are including the psychological care competencies, and psychological needs are routinely discussed now across the country in multidisciplinary meetings and so on. The real test is what the patients say, and we've yet to go back and ask nationally what patients think about their services, but in the teams that have made these improvements, patients are experiencing better psychological care. I'm going to stop now because I'm getting panicky messages. Thank you.
Sarah, thank you very much. Can we have a round of applause for Sarah? And having previously worked as a psychiatrist, we had a lot of patients who came through who could definitely benefit from that, so it's definitely something that's worthwhile.